So the person who haven't joined, that question will be referred to the audience. That's fine, Professor LARJAVA?
Yep, all good.
Or anybody from this college can answer that question, whoever wants to.
Absolutely,
Okay.
whoever.
Okay. So start it, please.
I can start now.
Yes.
Thank you, SAIF. So this is the last day of the GIAN course, and we are doing something different that we were thinking about doing in person in Aligarh, but that never happened. So we are trying to do it online, and I don't know exactly how this is going to work, but we will try anyway. So if it's a disaster, we can always jump in and go to the next part of the program. But let's play a little bit with the case of Mr. Bill Williams. So the background for this case is that this is one of our training cases for the dental students in our school. So we have a case-based learning. They used to call it problem-based learning, but then it became more of a case-based learning. So we wrote cases. So in the curriculum, we have 8 or 10 cases that the students will go through. They are typically run in 2 sessions. There used to be 3 sessions, and they are about an hour and a half each, where the tutor, the instructor will guide the session, but will not give the answers. So I will be your tutor, and I can be a tutor for you without knowing the answers. I don't have to be a context expert, because if there are some answers that you don't know or doesn't come up, they will be what we call learning issues. So if there are some questions that nobody can answer, they become learning issues, and then you can figure the answers on your own. So that's how we operate. So we usually have 1 session. The student will come with some answers to these questions. There are some that they don't know. We will ask them to go into the books or journals or whatever information they have, and then come to the next session with some of the answers. But recently, we have also changed this format that the instructors can they can be very flexible with the case. Like if there are areas of knowledge that we identify the students don't know, we can spend more time on that. And then in the end of the case, we will publish the tutor guide. So they will get the answers to the questions anyways. So, I mean, we can do the same because SAIF has the tutor guide as well. So he can distribute that to all the participants so they will know the answers. So it's just a kind of a nice exercise to apply some of the knowledge that we have gained over these last 4 days. And put it in a case in some degree of complexity anyways. So we will see how it goes. So you are now, whether you are professors or students or practitioners, you are all students who will be solving the case of Mr. Bill Williams. So let's get started. So every year we try to update these. So there are some information for the tutors that I have here. So the learning objectives is good to know. This is mainly for the tutors, but now this group needs to kind of know what the purpose of this case is, what the learning objectives are. So they are to explain the pathogenesis of periodontal abscess, describe the clinical management of the abscess, describe the relationship between diabetes and periodontal disease, smoking and periodontal disease, the 2 major risk factors or for periodontal disease, and then describe factors that delay wound healing in patients who have diabetes and who smoke, and describe relationship between smokeless tobacco, recession, and white lesions. So I will give these kind of a learning objectives already, although the students don't typically get this part, so they don't know what the learning objectives of the case are until we kind of publish the case. So who is Mr. Bill Williams? So Bill Williams is a 39-year-old Caucasian male who is a professional trumpet player. He's presently pursuing an education degree and playing trumpet in the clubs at nights. He presents to your office as an emergency patient with chief complaint that he keeps getting painful swelling on his gums that interfere with his trumpet playing. And then everybody can have a look. We go through the intraoral images that are not necessarily that's sharp, but I think they will illustrate what the case is all about. So when you look at the maxillary dentition, there are some loss of tissue, obviously some recession all around. There's loss of papillae between the teeth, so there's something going on here. They don't look necessarily nice and pink all around. At the lingual surfaces, the same kind of findings are present, some staining. So clearly some attachment loss is going on. Here are some images where the the biofilm has been stained with red stain, like a red coat. So it will illustrate what the hygiene level of Bill Williams is for the case. So these are the lower teeth, but you can see the amount of biofilm sitting on the teeth, on the lower or the posterior mandible. There's some spacing of the lower teeth. And then in quadrant 3, between the 3-3 and 3-4, you can see clear swelling of the gingival tissue in this area. So this is the area that when Bill puts the trumpet in against the lips, it will press on that canine area and feels painful. So that is his main complaint. It's not so much anything else, like, you know, my gums hurts right here when I start playing my trumpet. So you can see attachment loss in the posterior mandible with clear indications of presence of biofilm. And then when we go to the quadrant 4, we have these kind of, the image is not that clear, but clearly there's some white patches in the gingiva all the way to the vestibule. So there's white surface into the gingiva, so it doesn't look normal. So something is going on there. So these are the clinical images that you kind of now memorize, that there is generalized attachment loss that is visible, or hygiene doesn't appear that great. There's some spacing, especially in the lower anterior. There's swelling of the gingiva between the 3-3 and 3-4. And there's some sort of white lesions present in the quadrant 4, around the 4-4 and 4-3. So I will skip the guiding questions because they are only for the tutors. So we will go to the first questions, because this is the patient's main concern, and that is a list of or causes for dental abscess.
Oh,
So
should
this will
I?
this will be
Okay,
for the first group
yes,
to
yes. That is
answer.
PGI, the Rohtak group. Dr. Janvi and Dr. Rinda have to respond. Dr. Rinda Sharma, please open your camera and respond to Professor LARJAVA's question. List of the causes of dental abscess.
Good morning,
Dr.
sir.
Rinda Sharma,
Myself, Dr. Janvi. We are not able to open the camera. I don't know what happened here in the
okay,
video
sure,
part.
no
We're
problem.
trying to connect
Just,
also.
you are from
We could
PGID.
speak up.
Okay, sure. You are from
Yes,
PGIDS
sir.
Rohtak. So you will give the answer.
Yes.
Yes, first one.
So the cause of dental abscess could be periodontitis related or non-periodontitis related. It could be due to acute exacerbation in the tortuous pockets, furcation, or vertical defects in periodontitis patients who are not undergoing any treatment, or due to recurrent periodontitis, or the patients undergoing SPT. The abscess can also form after in subgingival scaling and root planing, or in surgical procedures, or when the patient is on long-term antimicrobials. In root planing, the calculus can get dislodged into the subgingival space, and the
Your voice is not.
caudal part of the
Your voice is not
in
coming.
non-periodontitis patients can be
It's
Dr. Rindap, it seems your internet connection is not stable. We don't have much time. We'll move to the next question if you guys don't have an answer to the first question.
I mean, we did get most of the responses this already, so
yes.
I think it's gonna be okay. So I will kind of I think they were mostly on the point. Like, this is not the competition who has a right answer and wrong answer. This is just a
You tell. Should I give?
little.
We give points. If you want to give, we can give points to the colleges also. It's up to you,
No,
Professor LARJAVA.
no, we don't need. This is just a
Okay.
fun exercise that we're gonna do in the
Okay.
end of this course. So obviously, you're gonna have swelling of the gingiva if you have a periapical abscess, root canal related issues, or periodontal abscess that comes from the deep pocket that doesn't drain. So that can come from the, just having lots of calculus there, or incomplete debridement. Somebody has dislodged a chunk of calculus and then the pocket doesn't drain, because typically pockets are open, they drain, so we don't usually have periodontal abscesses unless somebody will block that drainage in periodontal disease. Sometimes systemic antibiotics can if patients are just given an antibiotics and no debridement, may lead to an abscess, although you will think otherwise, but with the bacteria are still there. Trauma, and you may have foreign body that goes into the tissue and is causing the foreign body related abscess by itself, or it can go into the periodontal pocket. So you can have a popcorn sliver or any kind of a food getting trapped into the site, and then you may have abscess. Diabetes patients are medically compromised, and they are more prone to have these abscesses. So it's quite typical for them to have much more easily abscesses than patients without diabetes. Pericoronitis, that's a kind of an abscess around the wisdom teeth mainly, and then you could have abscesses, of course, around erupting teeth, especially if something goes underneath that tissue that is surrounding the erupting teeth. So then the next question is, how does the abscess then form?
Question is for Atal Medical University, Himachal Pradesh, and I think who is from Atal University, Himachal Pradesh?
Yes, sir. Yes, sir.
Please respond to Dr. LARJAVA's question. How do
Yes, sir.
periodontal
Yes,
abscess
sir.
form?
Sir,
Please open.
good morning, sir. Yes, sir. The answer to this question is, according to Carenza, a periodontal abscess form when the bacterial infection within the periodontal pocket extends deeply into the supporting periodontal tissues, which is leading to the localized collection of the pus along with the lateral aspect of the tooth root, often results in the sinus tract through the bone that drains the infection to the external surface of the gums. That is causes the cause for periodontal abscess we have already discussed, like poor oral hygiene, plaque buildup, and proliferation of the bacteria into the deeper pockets. Thank you, sir.
Well, that is a pretty good presentation. So as we already discussed, something builds it up or it's deep enough and doesn't drain, and then it gains access to the least resistant way to drain the pus and the inflammation. So let's move to the next question. What happens if periodontal debridement, root planing, scaling and root planing is carried out incompletely, especially in the deeper parts of the pocket? Kind of follows the same line as previous questions.
So this question is for SGRD Amrit sir.
Good morning, sir. So the answer to this question is that in case of incomplete debridement, we'll be facing with the persistent infection, as stated by Max et al. In 2020. If infected or not clean, bacteria cause the disease and remain in the pockets for the longer time, thereby leading to increased infection. Secondly, we'll be facing delayed healing. That is, the removal of biofilm and calculus is crucial for tissue regeneration and wound healing in periodontal treatment. Thirdly, we will be facing with the spread of infection, as stated by Ahmed et al. Incomplete removal of plaque and calculus will exacerbate the infection, leading to further tissue damage and spread of the infection to adjacent periodontal tissues. Recurrence of the abscess will be seen, as stated by Page and Conman. Incomplete periodontal treatment leads to recurrent abscesses formation with increased effect to the sporting tissues of the tooth and ultimately leading to the tooth mobility. Then the other complication which we can face is systemic health will be affected. As we already know that with the persistent calculus and plaque, the periodontal infection, if persists, it will lead to further systemic diseases including diabetes, cardiovascular disease, infective endocarditis, and currently Alzheimer's disease is being researched in this context. Thank you.
Very, very comprehensive answer. And I don't need to read what's the answer is here, but why we are asking this from our dental students is that many times when they have patients who have calculus and deeper pockets, then they just say that, should I just, first round I will just take the big chunk out and then the patient will come back a month later. And we tend to say that, no, try to do it to close to completion, and then okay, you have to do some fine tuning in the second round if possible. So we don't want them to dislodge the big chunks of calculus deeper into the pocket and cause abscesses and other problems. So that's why this question was here, that we try to get them to do as complete debridement from the get-go rather than just do some superficial scaling and then leave the rest. So, and then the next question. That has very easy answers. So is anybody willing to?
So it's for the UPMS SAIF to answer. Could the patient have a medical condition that make him more susceptible to developing the abscesses? This is for UPMS SAIF. I think Dr. Divakar should answer.
Yes, sir. Good
Yes,
morning,
you
sir.
answer this
Myself,
question.
Divakar
Yes.
from UPMS
Good morning.
SAIF. The medical conditions which are involved in the which are more susceptible for the abscesses are diabetes mellitus and skin immunocompromised conditions such as HIV, tuberculosis, and the patients who are long-term usage of steroid and the cancer patients who are under chemotherapy. These are the medical conditions which are who's mean the patient who are more susceptible for abscesses. Thank you, sir.
Very, very good answer. Very comprehensive answer. And we were hinting here already that maybe there are some potential ideas of diabetes in this case. So we will move on and now Mr. Williams has completed the health questionnaire and you review it with him and asking questions to extract additional information. Then you conduct a clinical examination and take the attached full mouth series of radiographs. So let's view some of the radiographs now. I apologize that some of the radiograph copies are not that clear, and even our students have complained about it, but it will give you a glimpse of what's going on, especially on this side. The other side, the copies have been burned so badly that this quality is not that good. But let's review them together. I mean, so the impacted wisdom teeth in quadrant 1, and there seems to be some reduction of the bone level. The 5 bone level looks pretty good, and then there's probably more than 30% bone loss around all the anterior teeth. There's some spacing between the teeth, which is typical for more advanced periodontal disease because the forces are no longer in balance. So the teeth start displaying out. And basically the same thing continues here, although it's not that visible. And again, the other wisdom tooth is still there. Continuing the lower, similar kind of findings, we have mainly horizontal bone loss, probably 30 to 40, maybe 50% in some areas, and that continues in the lower mandibular anterior teeth that probably have like 60% bone loss, so only 1/3 of the roots are in bone anymore, and then bone loss continues about 50% in the last sextant, and there's another impacted wisdom tooth. From these images, it's kind of hard to see the level of deposits on these teeth, but in some areas you can see a little bit calculus deposits that are actually quite generalized in this case, but you just can't see them in this radiographs. Unfortunately, the quality is relatively poor, but we get the glimpse that this patient has advanced and generalized bone loss, and it's mainly horizontal, anything from 30 to 50, 60% throughout the dentition. So something is going on. Then you do the probing measurements. If you look at the probing records now only with the probing numbers. So these numbers are the buccal labial numbers, and these are lingual probing numbers. So we have generalized 5 to 7 millimeter pockets throughout the maxilla. And as I pointed out, even in the radiograph, there are a couple of teeth that are kind of doing okay, but most of the teeth have 5 to 7 millimeter pocketing throughout. Some of the molars have class 2 furcation defects. And when we go to the mandible, then we have anything from 5 to up to 10 millimeters distal of the lower molar for 7. with the class 2 furcation. The other molars have either class 1 furcation defects or nothing at all. This probing sheet doesn't indicate the recessions. We have another screen in our computer system at UBC that will show all 3 numbers, but I have simplified this and only took an image of the probing records because we have seen some of the recessions already from the clinical images. So those numbers that are, so in our school, we tend to put any probing records that are 5 and above with red, as you can recognize in the charting. So this is Axiom program that we use in the school, so that different dental offices have different digital programs. So this is one of those. And there's much more information, but it's kind of simplified for the purpose of the case. So here are the numbers with the recessions. So it's getting a little bit more complicated because you have the middle numbers. It doesn't record zeros. So the middle numbers are the recessions, and the top numbers are numbers of the attachment loss. So of course that's the probing depth plus the recession number. We don't record negative numbers. So if the gingiva is swollen above the CJ, we don't record that. So so the recessions are somewhere between 2s and 3s and throughout the dentition. So it's pretty generalized overall, 1 to 3, 4 millimeters of recession around the teeth. So let's go through the health questionnaire. So the chief complaint remains that the gums swell and are painful. It makes sometimes difficult to play my instrument, which is trumpet. And have been attending regularly a dentist, except haven't been going lately that much. And I only go with when I have a problem. So 2 years ago, his dentist told that he has gum disease, that should have the teeth cleaned every 6 months, but I missed my appointments because I was busy traveling and playing trumpet. When I get swelling, I get antibiotics from the dentist or my doctor. And last cleaning was 8 months ago. There's no information about family history of periodontal disease. Using medium stiffness brush, changing twice per year, brushes twice per day for a minute, using modified bass technique, technique that was advised 2 years ago, and doesn't use any other aids. So Bill Williams is a 39-year-old Caucasian male who is a professional trumpet player. He's presently pursuing an education degree and playing trumpet at clubs. His wife left him, and his father has recently had a quadruple bypass, so heart condition. No regular doctor, goes to walk-in clinics. Okay, when needed, has a steroid for eczema, and most of the things. So he will indicate that he has some heart problems, but everything else is kind of a no. Even diabetes is no in the health questionnaire, and everything else is no. And his health hasn't really changed. He has lost 10 pounds over the last year, and he thinks that because he's so busy, doesn't seem to indicate any major illnesses, but he does answer to the questions how you heal, that I'm healing slowly. So there's an indication that maybe something is going on, and that relates to our course objectives too. No allergies, no asthma, Chest pain, like, patient tick that heart condition. There's a physician, so his doctor said that the pain is related to the muscle pain associated with stress. So no heart condition was diagnosed. Patient feels thirsty often, and father had a heart attack. And then he thinks that he's a pretty nervous patient. He smokes quite a bit, 10 to 15 cigarettes per day for 20 years. His blood pressure is kind of in the normal range. So, and the pulse and respirations are in normal range. So the medical summary is that this is a 39-year-old Caucasian male using occasional steroid cream on hands and for eczema, has occasional chest pain that has been attributed to the muscle tightness by the physician. This is a concern to the patient, as his father survived a heart attack in his mid-40s and had a quadruple bypass in his 60s. Smoked cigarettes, 20-year history, reports cut on his arm that did not require stitches or antibiotics, but took a long time to heal. So when you do the extra-oral exam for the patients, there are really nothing obvious findings. There are no significant findings. Then you'll do the intraoral exam. So you notice the white lesion that we already saw in the keratinized tissue. It asymptomatic. White fold extends to the buccal mucosa. Recession on the neighboring teeth is present. Angler class 1 dentition, buccal abscess associated with the teeth 3.3 and 3.4. Oral hygiene effectiveness is only 33%. So based on the dental and medical history, clinical examination and radiographs, what are the patient's medical findings? Okay, I will hide what they are. You can summarize them for me.
This answer has to be given by AMU group will answer this question.
Okay.
The AMU group.
So
Dr. Nancy.
So the medical history of the patient is 39-year-old and gives a history of smoking, that is 20 packs per year. Also, the patient gives a history of delayed wound healing, as there are some cuts on his hands which took almost 2 months to get healed. Secondly, patient also gives the history of recent weight loss in over past 1 year of almost 10 pounds. Also, there is a history of chest pain and related to some heart problem that he had suffered previously, and he also gives the history of stress, as he's constant. He remains nervous while playing the trumpet, so he must be under some stress. And he also takes topical steroids for the eczema on his hands. So all these history signifies to some underlying systemic condition that he must have suffered and that needs further investigations to rule out.
Very good. Stress, smoking, poor healing, family history. So how about the oral findings?
This answer has to be given by RUHS Jaipur. RUHS Jaipur. Anybody from?
We have Jyoti from RUHS Jaipur.
So, Dr. Jyoti, please answer this.
The oral findings.
Yes.
We cannot hear you, Dr. Jyoti. So should I?
Answer this question, Professor.
She's here, sir. She's here.
The answer for oral findings.
Please speak louder, Dr. Jyoti. We cannot hear you. No, not audible.
Audible?
Yeah, now you're audible.
There is presence of generalized recession with clinical attachment loss. The presence of swelling is present with respect to 3.3 and 3.4. The presence of white lesion is present with respect to 4.3 and 4.4 on the extending on the buccal mucosa. There is also presence of inadequate attached gingiva in the fourth quadrant, and there is presence of multiple carious restored teeth. The embrasure type presence is type 4 embrasure, and also there is presence of pathological tooth migration, generalized spacing in the lower anterior region, and the presence of stains and debris.
Very good and comprehensive. Could I ask how would you diagnose this case? Because I don't know if the diagnosis comes up using the AAP 2017 classification or the old one or both, in terms of periodontal diagnosis anyways, because we can lead you from the findings to the diagnosis. So I don't think we have a question about the diagnosis in this case, but I think we should. So I was looking through the case and I didn't see it, so we will make it up now on the spot.
Whoever wishes to answer, please open your mic among the participants from 7 colleges.
Class 3 grade B.
It's a class 3 grade B type of periodontitis according to AAP 2017 classification.
And is it localized or generalized?
Any other team would like to answer?
Generalized it is.
Very good. So that will be my diagnosis as well. But there are a couple other diagnoses that you can probably give as well, in addition to the periodontal disease. And how would you diagnose it based on the classification before 2017?
We would request any other team to answer.
So it will be staged as stage 3 periodontitis, and the underlying cause is unknown to us, or we are unknown to any systemic condition. So we'll categorize it under grade B.
Yes, but if you go to a classification that was in use before 2017, how would you diagnose this?
So
Based on the old classification.
Moderate case of generalized periodontitis with moderate grade of severity.
Any other answers?
I mean, I can help out. I mean, we can all kind of, it's never a precise answer. I mean, the important thing that we recognize it's periodontal disease, but then all the definitions, sometimes we disagree, the grades and all the rest of it. In the olden days, it was relatively easy because you could call it this moderate to advanced generalized chronic periodontal disease. So that's what it was in the past, and we didn't give it the grading and all the rest of it. So sometimes in some ways it was easier to diagnose these patients, but I was looking for the other diagnoses that we typically give these patients because we make a list. And periodontally here, we always give additional diagnosis for the abscess, and then at least for the lesions on the we try to diagnose, and if we can't do anything else, we will just say that it's a leukoplakia, like a white lesion for that sulcular lesion on the quadrant 4. So at least those kinds of things that we would like at least our students to answer. And I suppose I had a question to SAIF that, or anybody that, how common it is in India that you will have case-based learning cases for the students. So, I mean, this is probably all familiar to you already. Can anybody answer?
Yes, it is common. We do it. Not so much. The UBC is very much comprehensive. We do case series, but yours is very much comprehensive.
Okay.
That is, yes.
So let's move on. I mean, we had all these findings, and then we discussed the diagnosis as well. So that's all good. We have, in this case, the tutor is asked to not make a case about the stress and periodontal disease because it opens another box. So we want to focus on this case. So we will kind of leave the stress out of the case. And the next question is, how are you going to manage the patient's chief complaint at this emergency visit?
This question is for DJ Dental College.
As the patient is having a chief complaint of getting a painful swelling at his gum, so first we do the debridement of abscess area under the local anesthetic anesthesia. Then we start with the analgesics and antibiotic therapy. Plus we motivate the patient to discontinue the smoking.
So you are exactly right, but most of, if they are localized abscesses in Canada, we try to avoid giving them abscesses if you can locally debride them. So only if they have some other symptoms, like if they have fever or something else going on, we will give them antibiotics. If we can manage, if we truly think that it's a periodontal abscess and we can truly debride it, we don't give patients antibiotics necessarily, but
Yes.
different countries have different rules and regulations, and different colleges may have their own things. Like it is in this list, but
Yes,
typically we try to avoid. So there's now a trend around the world that we try to avoid using antibiotics as much as we can, because of the resistance. So whenever we don't have to, we don't use them. So, but good answer.
Thank you.
So now you have treated Mr. Williams, who is now happy with the care that he has received. So he wants to become a regular patient in your office to have all his dental needs addressed. So the chief complaint has now been addressed. Based on the medical concerns previously listed, how would you proceed with your investigations, and do they affect your treatment? So who would be answering this question?
This will be answered by PGIDS Rohtak Group. So PGIDS Rohtak Group, please respond this to
Yes,
Professor
sir.
Valedictory's question.
Good morning, sir. Since diabetes mellitus is suspected in the patient, so we should proceed with a glycated hemoglobin test, that is HbA1c test for diagnosis and assessment of the patient's past 3 months diabetic control and his condition. Based on the test, if he gets a reading of above 7, he needs to improve his diabetic control. And we can also check for fasting blood glucose level and 2-hour postprandial. If fasting is less than 126, the patient is good to go. If it is less than 200 for 2 hours postprandial, that means the patient is a non-diabetic. Random blood sugar at the time of appointment can also be checked. It should be less than 140 mg per deciliter. Then a thorough history has revealed that the patient is an active smoker and smokes about 15 to 20 cigarettes per day since the past 20 years. So about 20 pack years. So in such a case, tobacco cessation counseling should be done. Patient can also be put on a nicotine replacement therapy with bupropion or vernicillin.
And also psychological counseling for stress reduction should be done. Since the patient is also suspected to have a leukoplakia, which is a white lesion in the mucobuccal fold, a biopsy should be done of the lesion because it might be precancerous. To rule that out, we need to do a biopsy. Also, medical referral and regular cardiac checkups as the patient develops cardiac pain that as of now has been related to stress, but can also lead to further complications because his father is a cardiac patient. Also, oral hygiene instructions should be reinforced as the patient has poor compliance and has reduced brushing efficiency of about 33%. Since he has a recession in some of the teeth, in those areas, modified Stillman technique should be demonstrated to the patient, and in the other areas, a modified Bas technique should be good for the patient. Thank you.
A very comprehensive answer. So thank you very much. So I don't really have a lot of to add. So obviously this patient has some signs that he may be diabetic. So in Canada, we will then inquire from his physician, if he has a physician, that's sometimes a problem, and send a letter to the physician to the examination, because basically dentists should not be diagnosing diabetes. It should be a medical doctor who will do that. So we will write a letter to the physician asking, telling, like the dentist student or whatever will write to the physician a letter explaining that, you know, there are abscesses and then, you know, there's a concern that he may be undiagnosed diabetic because of the weight loss, recurrent dental abscesses, poor healing, family history, and you name it. So basically asking the physician to make the diagnosis. I know that in some clinics, the dentist can do the glycosylated hemoglobin measurements in their office and then use that as a guide. But we have to get the medical folks involved in the treatment anyway. So we send them to the physician, and then what in this case we have received a letter back from the physician saying that thank you for your referral, and he does indeed have uncontrolled type 2 diabetes, and then fasting plasma glucose level is 160, glycosylated hemoglobin 11.1, and as we have discussed, we would like this to be closer to 6 than 11, so clearly he's not controlled. And he has now started the metformin treatment and some dietary information given, and appointment with the nutritionist and so forth. So now he has a diagnosis. So we will then continue, and I don't need to ask this question again because I think it was already covered in the previous answer. So it will go through all the different medical tests for diagnosing diabetes, and some of that was covered in the previous presentations during this week. So we, for the time's sake, we don't have to go to details of discussing these most of these tests. So we can kind of jump over that a little bit. I mean, we were discussing all these numbers and then how we, and I think they're fairly similar in India that they are in Canada. I think they are internationally, the guidelines are pretty similar in different countries. And in the maintenance phase, we use the glycosylated hemoglobin levels that we patients like to be I mean, 8 is a little high in my opinion, so it would be nice to have around 6. And the people, when they are getting over 7, the control may not be very good. So different countries, different guidelines may have different levels of clinical interpretation, but I think everybody agrees that it would be nice to have, 6 to 7 and or in that range, and not having 10s and more, or something that fluctuates all the time. So but we could answer the question, what are the major complications of diabetes and what the pathological mechanisms might be, because that also relates to the case. So I don't know if there are anybody signed for this.
I'm going to reassign because this question will be answered by Atal Medical University, Research University, Himachal Pradesh. Who is from Atal University? Dr. Priya will answer this.
Yes, sir. The question is, what are the major complications of the diabetes? Describe any 2 pathological mechanisms. So, as the diabetes has a two-way relationship with periodontitis, so as we know that periodontitis is the 6th complication of the diabetes, there is a various studies which has been said that we may see the multiple sinus formation, burning mouth sensations, and the dry mouth, which is related to the high risk of caries and decrease of the salivary flow. These are the major complications of oral cavity we can see.
I mean, that's a good answer. We were perhaps looking more of the what the kind of overall, not necessarily only periodontal disease complications are, like they have the eye problems, kidney problems, and neuropathy, and circulation problems that are a result of the hyperglycemia. So the mechanisms are multifold, but one is that there's a polio pathway that may result in the sorbitol production, and that may be toxic for the tissues. And the main products that are produced by having additional sugars is that many proteins get sugar added to them, so they get glycosylated, and they become these advanced glycation end products, and they are the pathogenic culprits for diabetes. And as you probably know, we can create these by frying things on the pan too, so they can be environmentally or part of the cooking process produced. So and the cells have receptors for these products that then lead to all kinds of issues with the inflammatory regulation, high cytokine levels, the matrix proteins get glycosylated, and their function will change, and so forth. So that's what we were kind of looking. So we can jump over the glucose test, and then, because I think this question was partially answered with the previous group, the relationship between diabetes and periodontal disease. So I can kind of go in some of those functions. So as you know, PMN cells, the polymorphonuclear leukocytes, are the main cells. We have discussed this many times during this course, that they are the main cells that come through the gingival crevice, and south of the border, our friends in the Seattle have shown that even if you don't have bacteria, which is quite intriguing, you have these PMN cells coming in chnotobiotic animals through the sulcus without stimulation of, because they basically don't have any bacteria. There must be some evolutional kind of a mechanism why these PMN cells are still coming into the mouth, even if there are no bacteria whatsoever in the mouth. So, but if you have bacteria, you have lots of it. So you have lots of polymorph leukocytes coming in the mouth. And if you have advanced periodontal disease like this Bill Williams case has, there's a lot of PMNs coming into the mouth every day. Like we calculate the clavicular fluid levels going up to, it can be up to 50 milliliters per day. So it's a big volume, because usually it's only like fractions of a milliliter. So it will dramatically increase, but these cells are not functionally capable in diabetes because they have reduced chemotaxis, adherence, and phagocytosis. So they are not able to protect the host very well. The collagen metabolism is changed. And then the advanced glycation end products will go to the receptors in many cell types. And then they change the matrix production. They will change the cytokine profiles in the inflammatory cells. So there's like a constant inflammatory mediator burst coming into the tissues, and that will cause more degradation. So, all right, who wants to answer if there's a relationship between diabetes and wound healing? We have covered it a few times.
So this answer has to be given by AMU Aligarh group or any.
Hello.
Yes.
The answer to this question is that yes, there is a relationship. Diabetes delays the wound healing. It alters each and every phase of wound healing, starting from hemostasis to the proliferation and modulations. So what happens is that the first line of defense, as just now described, is PMNS, and the response of PMNS is altered. There is defective chemotaxis, adherence is defective, and the phagocytosis action of PMNS is defective. And because of interaction of advanced glycation end products and the receptors of advanced glycation end products on monocytes and macrophages, there is dysregulation in their activity, and there is increased inflammatory phase of wound healing. This increased inflammatory phase of wound healing is responsible for increased pro-inflammatory cytokines, which causes more destruction, so hence delays the wound healing. Not just that, the main cell which is responsible for the proliferation of wound healing is the fibroblast. Their actions is altered because of hyperglycemic conditions. So the new collagen formation is defective and reduced, and the collagen which is already present, there is increased cross-linking of that collagen, which causes the formation of advanced glycation end products. So the overall turnover rate and the quality of collagen that forms is altered. And coming to the bone, increase MMPs, the more collagenase is also there. And coming to the bone healing, there is increased fraction of rankle to opsonins. So there is more activity of osteoclast in comparison to osteoblast. And all these mechanisms eventually led to a delayed wound healing in a diabetic patient. And one more thing is there's the dysbiosis. It is mainly an anaerobic environment in a diabetic patient. So if diabetes is not controlled, this anaerobic environment will lead to harboring more bacteria, which causes more destruction, hence even more delaying the rate of healing.
Thank you very much for comprehensive answer, and we have discussed that in several lectures already. So we can move on. And then the practical question to the next group, like, is there a special protocol required for performing dental procedures on diabetic patients? So I mean, that was a little bit covered, but let's go through that one more time.
So this has to be answered by RUHS Jaipur group. RUHS Jaipur group.
Good morning, sir.
Good morning.
The protocol for diabetic patient is that as we know the HbA1c level of this patient is 11.1, that is more than 9. So in this case, we have to first postpone our surgical procedure. First, we have to ensure the blood glucose level so that to prevent the further infection and to promote an uneventful healing. We have to schedule the appointment according to the meal and the medication timing of the patient, so we can prevent the hyperglycemia, and also by a reduction of the stress and calming down the patient, because in case of stress, the hyperglycemia will get increased. So we have to go through first the stress of the patient should be reduced, and we have to maintain the strict aseptic condition while performing any of the surgical or non-surgical therapy. And antibiotic prophylaxis for the patient should be given as the patient was having uncontrolled diabetic mellitus.
Very nice. So patients who have these kinds of numbers, if they are not improving, they will probably any kind of invasive procedures, they probably will need antibiotic coverage. And I mean, they try to, manage their appointments and so forth. But like if the patient is recently diagnosed, I hope that they are closely followed, so we will know when they are getting better, and then if they are getting to the normal range, then basically they can be treated as anybody else if we can get them to the level of 6 to 7 area. And then they don't need antibiotic coverage necessarily anymore if they are well controlled. So that was a good answer. So the next question. Do we have anybody?
Yes, we have BJ Dental College, Modi Nagar, to answer this.
Yes, sir. Sir, no, it's not semi-audible.
Are you?
Hello?
Yes, you're audible.
Sir, yes. So no, it's not a normal response, though plaque is a main factor, but there's smoking and uncontrolled diabetes. They are contributing factors because uncontrolled diabetes that impairs the immune response and reducing the body immunities to fight the infection. So there is a delayed wound healing, and due to the smoking, there is a reduce in the blood flow, it impairs the immune response and promotes the growth of the anaerobic bacteria.
Very good answer, and I like that, because in our Tulurkau we didn't necessarily mention the second big thing that this patient has, which is smoking. And it's good that you are bringing the smoking and stress into the picture, because it's not only diabetes, there are other things going on at the same time. So they all kind of accumulate together. So that was a good answer. So let's move to the number 14.
Has to be responded by this PGID Rohtak group. So PGID Rohtak group, please response to this question. Why does this patient have recurrent dental abscesses? 3 reasons.
Yes, sir. Yes, so there can be 3 main reasons in this present case. First, it can be because of uncontrolled diabetes mellitus. The healing capacity of the body is reduced. This happens because there is formation of advanced glycation end products. Because of the Maillard reaction, the collagen fibers, they undergo glycation and they are more prone to breakdown, and they don't repair very nicely. Also, there is reduced chemotaxis, phagocytosis, and adherence of the PMNs. Also, in patients with diabetes mellitus, there is change in the microbial composition. There is increase in the black pigmented species. All these factors can lead to delayed healing. Then the second factor is smoking. The patient is a heavy smoker, that is about 20 pack years. And smoking reduces the response to periodontal treatment. Also, in this case, the oxidative burst is also faulty. There is increase in pro-inflammatory markers like TNF-alpha, prostaglandin E2, MMP8, and there's also increase in GCF elastase. The smoking also alters the microbial composition. It increases the red complex bacteria like P. gingivalis, T. denticola, and T. forsythia, and also increases the orange complexes. Again, because the patient uses an occasional steroid cream for his eczema, steroids again delay wound healing. They increase hyperglycemia. So already the patient is diabetic, and steroids also increase hyperglycememia. So it delays the healing. Also, there is increased protein breakdown because of steroids, and also an increase in decrease in osteoblastic activity and increase in activity of osteoclast. Vascularization is also disturbed in cases of steroid application. All these three factors can, with this, there is also persistent stress that the patient is undergoing. So all these factors can lead to improper healing and can cause recurrent dental abscess.
Very comprehensive. However, you could have also elaborated that why this particular patient has these abscesses is likely also related to the periodontal disease that is present in this patient, because you can have a diabetic who doesn't have periodontal disease and they are not necessarily likely to get dental abscesses all the time as the patients who have diabetes and periodontal disease together. So, okay, number 15.
Has to be answered by Atal Medical University, Himachal Pradesh.
Yes, sir. So, yes, sir, there are further complications like oral manifestation, which is associated with diabetes mellitus, like xerostomia, dry mouth. There is an increase that increases the risk of caries and decreases the salivary flow. Patient may also complain by the burning mouth sensation here, which is associated with diabetes. Again, there's an alteration in the microflora in the oral cavity associated with the Candida albicans and cheilitis. We can also see the gingival polypoids and polyps, and patient may also suffer with a multiple sinus formation here. Thank you.
Very good. We can just move on to the next question. Number 16, is Mr. Williams now more likely to be prone to more periodontal disease in the future?
This question has to be answered by SGRD Amritsar Group. SGRD Amritsar.
Yes, sir. So definitely, Mr. Williams is likely to be prone to be more at higher risk of periodontal disease in the future. The reasons here are elevated blood sugar levels, which lead to increased glucose concentrations in saliva and GCF, thereby providing with the conducive environment for the bacterial growth, and because of which the bacteria will proliferate and can initiate and exacerbate the gum infection. Secondly, impaired immune response due to diabetes, which weakens the body's immunity, reducing its ability to combat infections, including those infecting the gums. So it will further exacerbate the periodontal disease. Reduced blood flow forms another reason. Diabetes impairs the blood circulation, leading to decreased oxygen and nutrient supply to the gums, which hampers their tissue repair property and increasing the risk of periodontal disease. The another reason which can be is the increased inflammation. Diabetes is often associated with heightened inflammatory response in the body due to release of pro-inflammatory cytokines, which can intensify and the severity of the periodontal disease further. Thank you.
That is all true if the physician cannot get the diabetes under control. So if the disease is under control, otherwise they may be more susceptible, but if they are well controlled, they will probably not proceed much more than anybody else. So it all depends how the diabetes level will be controlled. Is the composition of microflora or microbiome different?
So this question has to be answered by UPMS SAIF group. Dr. Devakar is there, I think.
Yes, sir.
UPMS, yes, please answer to this question.
Yes, sir. Yes, there is differences between microbial flora between diabetic and non-diabetic patients in chronic adult periodontitis, where the most importantly, the Capnocytophaga species, the anaerobic Vibrios and actinomyces species are more seen in these diabetic patients. And Zambio et al. He identified the different serotype of Porphyromonas gingivalis in diabetic patients, and many other studies such as Ojima et al. In who identify the P. gingivalis, which type 2 of firm gene, which is more virulent. And the GCF sample has elevated blood sugar levels, and this also has a increase in microbial flora. And recently, DNA hybridization where Treponema denticola, Streptococcus sanguis, Provitilla nigrans, and Staphylococcus intermedius and Streptococcus oralis were the microbial flora which has been increased in this diabetic individuals than non-diabetic patients. Thank you, sir.
Very good answer, much more comprehensive that we have in this tutor card, so that's always great. But I mean, we have good academics who can probably improve our document as we go along. So let's move to the next question, which is periodontal surgery contraindicated for Mr. Williams? Who
Has to be
answers
answered
this?
is Amy Aligarh group.
So, no, the periodontal surgery is not contraindicated in this case, but we have to ensure that the patient is has a well-controlled diabetes, and his glycemic status is also under control.
Very good answer. No, if he is well controlled. Are antibiotics indicated to attain glycemic control in periodontal patients with diabetes?
So this question has been answered by RUHS Jaipur group. Please respond to this. RUHS Jaipur group.
Am I audible, sir?
Yes, you are audible. Please answer.
The use of the antibiotic for glycemic control, there is a protocol specifically. The first thing is that the periodontal infection and the glycemic level should be under control, because periodontitis worsen the insulin resistance via systemic inflammation. And scaling and root planning can improve the HbA1c level. And antibiotics enhance the periodontal treatment, but there is uncertainty for the glycemic benefit. And the indication for the antibiotics, as we know that there should be, if severe periodontitis or refractory periodontitis is present, or highly risk immune compromised diabetic patient is there. And the common antibiotics are can be amoxicillin plus metronidazole, because it shows a strong antibacterial effect. Along with that, azithromycin, and as an anti-inflammatory benefit, we can give doxycycline, low dose doxycycline we should give to improve the tissue healing. And as the limited impact on the long-term glycemic control, the risk, the overuse risk, such as the disruption of the microbiota, gut microbiota primarily. And the approach can be scaling and root planning, along with the maintenance of the oral hygiene, and antibiotics can be used for this case.
Very good.
Yeah.
Okay, somebody needs to mute the microphone. Anyways, so there are some indications, as you mentioned, that antibiotics may be helpful in treating these patients, but overall, we think here that if the patient becomes well-controlled diabetic patients, the routine dental procedures don't need antibiotic coverage, but you can you have to consider, like you will consider with every case, whether you're gonna go with the shotgun approach with amoxicillin and metronidazole. I mean, we usually try to limit the patients who will get that shotgun kind of antibiotic regimen because it's pretty harsh. So, but if they become good patients and their diabetes is under control, they don't need antibiotics. So we will then move on to the, and we also kind of cover the periodontal disease and the glycemic control factors. So typically in this first part, and let's see where we are. So we can continue to the end of the case. So typically the students go through this in 2 phases, but we will just go straight to the second session and try to speed up the case. So we have learned all these learning issues from the first round that are listed here. And we move on to the next phase. So the patient's type 2 diabetes is now under control. So Bill Williams is doing well. So taking metformin. So he's concerned about his receding gums and the white lesion in his gums. So what are the causes for gingival recession? So I think I covered those in my lecture, but let's find out.
So this answer has to begin by SGRD Ahmed, sir. Kindly answer this question.
Yes, sir. Yes, sir. So the main reasons included in this are presence of supragingival and subgingival calculus, which can cause gingival recession, trauma from inclusion in cases of deep bite, thickening of gingival biotype and underlying bone, tooth position buccally with thinner bone and gingiva, frenal pull, especially seen in maxillary arch, use of hard toothbrush, which further leads to mechanical trauma, tooth movement due to orthodontic forces, improperly designed partial dentures can be the reason. In cases of smokers, it's been seen that gingival recession is present, and use of some cocaine implementation causing a gingival ulceration. Thank you.
Very good and comprehensive. So we can just move on to the next question. And that relates to the lesion in the vestibulum of Bill Williams, 4.3 and 4.4. So who is answering?
UPS SAIF group is going to answer this.
Yes, sir.
SAIF group. Dr. Divakar.
Sir, yes, sir. The history which I explained here is smoking is a habit of the patient, which almost 10 to 15 cigarettes per day for 20 years, which will give up the lesion known as leukoplakia, leukoplakic lesion. That is a cause for this white vestibular lesions. Thank you.
So I have a follow-up question to the group, or maybe it's another group or not. I'm not sure who is answering, but so if you have leukoplakia that is relatively localized into one area, like we know that smokers have leukoplakia, it can be very generalized and it can be through the palatal tissues and cheeks and gums, but it's usually fairly generalized. So Bill Williams has a very localized leukoplakia. So should we ask him some more questions, and what those questions should be? Yeah.
So maybe the stress which is present for the person, and he has skin lesions, eczema, might be the patient has lichen planus.
So so the right answer for this case is that because he's a smoker, he's also occasionally when he's in the bar playing his music and doing stuff, he's using smokeless tobacco in addition to smoking cigarettes, and he keeps the smokeless tobacco on that 4344 area, and that will explain why there's more irritation that is localized instead of being generalized. So some smokers, as you know, are using both smokeless and smoking. Some are only using the smokeless tobacco, and then they indicate where they keep it. And sometimes they don't answer the question that when you ask, do you smoke? They said no, and they don't say anything else. And then you go and find out the white lesion in their gums. And then you have to ask the questions, are you using smokeless tobacco? And then the answer in this case was that yes, he actually is. So that was the questioning. So let's go to number 4.
Number 4 is what is your clinical differential diagnosis of Mr. Williams' vestibular white lesion? What are the causes of localized white lesion? At least 8 causes. And this question is for RUHS Jaipur.
Okay. So, hear me?
Yes, you are audible.
So they may be due to presence of chronic mechanical irritation. It can be a frictional keratosis. Since the patient is taking antibiotics for long period, there can be a presence of it can be also be a oral candidiasis, which is more common in diabetic patients. And due to the presence of due to the chronic use of cigarette smoking, it can also be a presence of pre-malignant lesions such as leukoplakia. And also due to the presence of immunocompromised condition of the patient, it can also be a lichen planus. And due to the since the patient is a chronic smoker, due to the higher temperature of the cigarette, they can also be a chemical burns. And it can also be a oral hairy leukoplakia. And due to the immunocompromised condition of the patient, it can also be a lupus erythematosus.
Very good. So we're going to move on a little bit with the case. And kind of a summarize here that the patient is using the smokeless tobacco, and we already discussed the how effective is the question that do you smoke if they're using the smokeless tobacco. So can anybody answer to the what kind of a biopsy you will take, and what kind of fixative you will do? I mean, we are asking these questions because especially those residents who are in the periodontics program, and personally myself, I take a lot of biopsies of all kinds of lesions in the mouth. It's part of the perio training what we have. So I take out mucocells from the lips, and so little salivary gland issues. I take leukoplakia lesions all the time. Biogenic granulomas, all kinds of lesions are referred to our office, and that's part of what periodontists do. Not everybody likes doing them, so I kind of like doing them. So it's always nice to cut somebody's piece of tongue away, so to speak. So what kind of biopsy you would take, and which fixative?
This question should be answered by PGID's Rohtak group. Please answer this question.
Yes, sir. The type of biopsy would be incisional biopsy performed with scalpel, and it would produce the most satisfactory sample. We would attempt to sample the tissue that has been most severely and significantly affected, and we often select the site at the periphery of the lesion to ensure inclusion of healthy tissue in the sample. Adjunctively, we could also use a brush biopsy, but the use of brush biopsy routinely is debatable. And once the specimen is obtained, it is advisable to place it on a piece of paper with connective tissue side down for at least 1 minute to ensure that the sample stays flat during fixation. The specimen should be placed in 10% neutral buffered formalin with at least 20 times the volume of sample to avoid improper fixation or autolysis, and the fixative should not be changed or diluted. Thank you.
Very good. And I'm sure that you have a system where you send to the oral pathology. So we will send the biopsy to the oral pathology lab to be assessed. So let's talk about the number 7, gingival recession classification and possible surgical treatment options for the recessions on some of the teeth.
Atal Medical University, Himachal Group, please answer this.
Dr. Priya, please unmute yourself.
Oh, sorry. So, as you know, the gingival recession is classified by the Miller by the 3 classifications. Class 1 says that the recession does not extend beyond the mucogingival junction and no interdental bone loss is fine. So the full coverage is possible. Whereas in class 2, the recession extends beyond the mucogingival junction and no interdental bone loss is there, and again the full coverage is possible. In class 3, the recession beyond the mucogingival junction with the interdental bone loss or the tooth malposition, the partial full coverage is possible. In class 4, there is a severe recession with a significant bone loss and the malposition. So the root coverage is not predictable. And so according to this, so we can see clinically, in this case, the Miller class 1. But if we go for the radiograph, it seems that it's class 3 gingival recession. And the treatment option can be the free gingival graft, as it creates a white zone and ability of the treatment to the multiple tooth can be included at the same time. And secondly, we can go for the clinical, coronal DTR also. And we can go for the connective tissue graft and tunneling the modified Vista technique. Thank you.
Very good answer. So we can just move on. Those who are using the Cairo RT classification system, I kind of covered that in my lectures already. So, and you probably are aware that classification, it's very similar to Miller, a little bit different, but basically quite similar. So so now he's aware of his gums, and he asks what he can do to improve his periodontal health. So what changes would you recommend for Mr. Williams to make to improve his periodontal conditions?
So this
Number 8.
question, yes, sir, should be answered by SGRD Amritsar Group.
Yes, sir.
SGRD Amritsar Group.
Yes, sir. The first and the foremost recommendation would be to quit smoking, as smoking worsens the periodontal health and causes insulin resistance. Second would be that patient is educated about the increased sugar levels in the blood, which can further lead to increased systemic inflammation and lead to further complications. So we can the patient ought to do is emphasize, we can educate the patient regarding the role of the HbA1c, that is, it has to be less than 7% in order to reduce the periodontal inflammation. We can advise the patient to be attached more to the balanced diet, which is low in refined sugars, high in fiber, and rich in omega-3 fatty acids. Then we can educate the patient regarding the optimal oral hygiene maintenance, which plays an important role in maintaining the periodontal health, especially the health of the periodontal tissues. Then we can prescribe the patient with the antimicrobial mouthwashes, example chlorhexidine, to reduce bacterial load. And we can educate the patient regarding the lifestyle modifications, which include better use of supplements to combat infection, to increase the immunity of the body, and stress management to lower the systemic inflammation. And we can ask the patient to be regular with the follow-ups, as more frequent dental visits for professional cleaning and monitoring will be helpful to the patient. Thank you.
Very good answer. There's one, I mean, we have less things that you mentioned, and everything was good that you said. I did have a comment regarding when SAIF was talking about chlorhexidine. Was it yesterday or the day before? I can't remember anymore. I think it was a day before. So what I always try to emphasize to the dental students and the residents who are on the specialty program, that they always have to remember that chlorhexidine is a very good chemical compound to prevent the biofilm formation, but it's very poor on treating biofilm. So if you have a biofilm, it's pretty resistant to chlorhexidine. So many times it's still so common that that's why I'm trying to emphasize it for general dentists, that patients are coming to their office and then they just give them the bottle of chlorhexidine and think that will solve the problem. But existing biofilm is resistant to chlorhexidine. So again, in the case of Bill Williams, chlorhexidine would not do anything unless you will get improvement in oral hygiene levels first. So obviously, if you can, when we talk about the full mouth disinfection, if you know that concept, then there's a chlorhexidine as part of that disinfection, but the whole thing starts with the mechanical treatment that will remove the biofilm, and then you can prevent the biofilm formation with chlorhexidine. Just wanted to emphasize that a little bit more based on the talks that we had. So I will jump to the number 10 question.
This question has to be answered by AMU group. Please, AMU group, answer this question.
Sir, the clinical picture of a smoker differs from a non-smoker in terms of there's increased keratinization. So usually we see a thicker biotype in smokers, and there's smokers melanosis. So the mucosa is usually grayish to black in discoloration. Sometimes we can also see a smoker's palate, in which the whole palate appears white and grayish, and the minor glands, salivary glands on the palate appears, they are inflamed, so they appears reddish in nature. And usually if a smoker has periodontitis, so the severity of periodontitis is usually more. So these are the few things. And one more thing is the staining and the calculus grades are also more in smokers. So we'll be seeing more deposition of calculus in these patients. Thank you.
Yeah, maybe I would like to add the reduction in bleeding on probing scores, because I don't know if that was mentioned, but many times the patients who are smokers, and then we can somehow get them to quit, and then they start complaining that now my gums are really inflamed because they suddenly start bleeding more because the smoking effect is reduced. So very good. Let's move on.
So
that's the
this
amount
okay.
they roll.
So this question is to be answered by RHS Jaipur. Jaipur group, please answer it.
Yes, the amount smoked per day is directly affecting, as it is a grade modifier, risk and severity of the periodontal disease. And it is having a dose-dependent relationship between smoking and periodontal problems. The smoking quality influences periodontal health by increased clinical attachment loss and progressive wound loss. And as in this case, William is a heavy smoker, smokes more than 20 cigarettes per day. So there is higher risk of periodontal disease progression. Also, there is in smoking, there is presence of nicotine and toxic chemicals in the cigarette smoke that reduces the neutrophil function and impair the immune response, making the periodontium more susceptible for the periodontal invasion, thus reduces the immune response and healing impairment of a patient. And also in the heavy smokers, there is decreased bleeding on probing due to vasoconstriction, and which can mask the inflammation, and there is also presence of reduced gingival blood flow. There is also a dose dependent treatment outcome, as the there is implant failure rate are higher in the heavy smokers, and also the outcome of the periodontal surgery also impaired. Thank you.
Very good. And one of the reminders is the AAP grade modifiers that has one of those things for the grade modifier is the cigarette smoking, and they have put the threshold at 10 cigarettes being kind of an important thing. So yeah, the amount seemed to be playing a role. So let's move. Is periodontal treatment effective in smokers?
So, DG Dental College, please respond to this. DG Dental College.
Yes, sir. No periodontal treatment is generally less effective in smokers as compared to the non-smokers, because smoking negatively impacts the periodontal health and the outcomes of the various treatments. Like in non-surgical treatment, there is a reduction in the clinical gain attachment and reduction in the probing depth as compared to the non-smokers. Plus, it affects the host immune response and impair the neutrophil function and reduce the fibroblast proliferation, and which slow the healing. Plus, in the periodontal surgical procedure, it when we do the periodontal surgery, there is a decrease in the periodontal probing depth and reduction and gain after the open flap debridement, and there is increase of the deterioration of furcation after surgery, and there is also the increasement in the recession and the membrane exposure after the GTR. Plus, while doing the maintenance, there is increase in the probing depth during maintenance therapy. There is also a chances of the implant failure due to the negative impact on the osseointegration, and there's a higher incidence of peri-implantitis in smokers, leading to the implant loss over the time. Thank you.
Very good and comprehensive. So actually this session is much easier to run when we have professional folks answering rather than students who just sit silent in the room and don't necessarily have any answers to any of these, and many of them become learning issues in the end of the day. So I don't want to go to any more details on the smoking, except maybe we will jump to the questions that how we can help the patient smoking. Obviously, every country have their own kind of recommendations what we should do with the smokers in the dental office, and I'm sure that in India you have your own recommendations trying to get them to quit smoking, and in some countries the dentist can also prescribe some medications to do that. In some countries they can't. So that should always be the priority for overall future periodontal health. So maybe number 15 could be answered, that if the patient will stop smoking, that is the patient still at risk, or is that going to change? Number 15.
So SGRD Amritsar, please answer this.
Yes, sir. To some extent, we can definitely reverse the periodontal damage, as with quitting the smoking, there will be reduced inflammation, and smoking suppresses the immune response, making gum inflammation less visible. Once the smoking stops, the gums may appear more inflamed, but that is definitely the sign of healing. Quitting the smoking, better blood flow, that is the improved blood circulation to the tissues, thereby promoting their repair and regeneration. There are higher chances of improved immune response, which is generally suppressed with the continuous smoking over the years, and the body's ability to fight the infection is also suppressed. So in cases of smokers, the treatment success is definitely reduced as compared to the non-smokers. So with quitting the smoking, the results of scaling and route planning are much efficient as compared to non-smokers. What the things that cannot be fully reversed include the bone loss that has been caused with the smoking. Once the alveolar bone is lost, causing the periodontitis, it does not regenerate naturally and completely. However, regenerative bone graft treatments can be undertaken. Then, secondly, which cannot be reversed, is gum recession. That if any sort of gum recession has taken place due to smoking, it cannot be reversed, as gums do not grow back naturally. And third thing which cannot be reversed is attachment loss, as loss of periodontal ligament attachment does not fully regenerate, but quitting the smoking can slower the further loss. Thank you.
Very, very good answer. So we're going to move on, and we will actually now discuss the treatment plan. So who will make a treatment plan for Mr. Williams?
I asked
So
Mr.
it's
Dr.
not
Divakar. Yes, sir. I
okay.
asked UPMS. Yes, Dr. Divakar, please respond to this question. UPMS SAIF group.
Yes, sir.
Yes.
So
Please answer.
initially, the patient is educated and motivated to maintain their oral hygiene, and lifestyle counseling should be discussed with the patient and motivate the patient in order to cessate the smoking habit. Since the glycemic index of the patient is higher, so diet counseling has to be done, and refer the patient uh, to the physician in order to control the diabetes mellitus and the glycemic control thereby, and further to maintain the systemic health, and later advise the nutrition and diet counseling in order to maintain the same diabetes mellitus, and further whatever treatment we are giving to the patient. Prior to that, the compliance of the patient is very important. In order to achieve that, we have to motivate the patient to maintain the oral hygiene, and further in this case the abscess is seen, so emergency phase has to be done for drainage of the periodontal abscess, and further moving on to educate the patient with brushing methods, that is modified bars method other than the gum receding areas, where modified Stillman method has to be reinforced and demonstrated, and scaling and root planing as a non-surgical periodontal therapy. Further moving on to anti-plaque agent, that is 10 ml of chlorhexidine 0.2% has to be recommended for the patient twice daily for 2 weeks. Further, in order to maintain the systemic health and the abscess which is present in the patient, so antimicrobial therapy is recommended, and for every phase has to be maintained along with the maintenance phase, that is phase 4. So re-evaluation after every 15 days has to be done for the patient. Thank you, sir.
Any surgical treatment if things go well?
So for surgical, I ask AMU group to answer, please.
as Divakar sir has already stated, once the phase 1 is completed, there's a period of around 4 to 6 weeks. We let the tissue to heal, and we revisit the sites after 4 to 6 weeks. And the criteria whether to do or not to do phase 2 surgically at this stage is mainly depends on the residual pocket and the activity of the pocket. So if the residual pocket is 4 and more, and it's 4 mm or more and it's bleeding, so then we go to phase 2. Or if it's a deeper pocket of more than 6 mm, then also we proceed with phase 2. Now phase 2, depending upon the clinical features, can be changed. We can, for shallow pockets, we can repeat the phase 1 again, or we can perform open flap debridements, and we can, if the bone defects are there, we can go for either resective, and if the defect is contained, we can go for regenerative procedures. Thank you.
Very good answer. So with this level of bone loss, I mean, we will ask the students also, you know, what to deal with, what to do with the wisdom teeth and all the rest of it, and if they are in the area of the surgery, how to handle them. So that's something that you always need to think about it. If you do surgery here and you are planning to extract any teeth, and the tooth is, whether it's gone underneath the bone, so that you don't really have to worry about the wisdom teeth. But if there's a connecting pocket, then that becomes more of an issue that you need to consider what you're gonna do. So that's what we're gonna emphasize. But other than that, this probably will be an open flap debridement case, maybe some also recontouring a few areas. There are not a lot of vertical defects that we can see from these radiographs that could be suitable for regeneration therapy. So basically, it's going to be those areas that don't respond really well, open flap debridement, and then 3-month maintenance. So very good. I'm very happy with all my students. So let's go to the end of the story. So the pathology report stated marker hypokeratosis with mild basilar dysplasia consistent with the smokeless tobacco lesion. So this area was followed up, and I suppose the patient stopped using the smokeless tobacco, so it wasn't no more a problem. There was some perineal surgery that was done, and some teeth were extracted in this case. So I mean, that will be up to the clinician to make those calls. And then 3-month follow-up will be followed. So that would be the end of the case of Bill Williams. So these were the learning issues from the second part of the case, and everybody did really, really well. So I'm very happy. It was somehow related to the wound healing because we have a lot of wound. Well, we did some surgical treatment, and we had some non-healing wounds and things like that. So it's kind of related to the healing, and some areas probably in your country you may have a lot of diabetic and a lot of smokers, and they can come with those two together, and they compromise our what we can do and how we manage the case. So I will thank you, all the participants. You did really well. This went much better than I anticipated. Thanks to SAIF, who had already warned. So we didn't have to do it on the fly. That would have taken forever. So it was good that people had prepared for those answers. And if somebody really wants to have the tutor guide, I think some of your answers were more comprehensive than what we have in the tutor guide. So, but if you want to have it, SAIF can send you a copy of the tutor guide, and then you can maybe fill in the voids that we had in the guide. So thank you very much. That ends the case-based learning. Thank you very much.
Thank you, Professor LARJAVA. Can we can stop for 1 minute? Wait for 1 minute, and after that we'll have a session. I asked Dr. SHOEB to kindly invite Professor Rajesh Thakur to chair this session. We can wait for 1 minute.
Yes, thank you.
After 1 minute, we can start it. Yeah?
You have Professor Rajesh Kumar sir in this meeting.
Yes, I am here. Good morning. चेयर सेशन चल रहा है ठीक है भेज दीजिए चेयर सेशन चल रहा है अभी चल रहा है अभी उसके बाद देखते हैं यही बैठे करते हैं करो सर को कौन देखेगा सर को देख लो
Do we have Professor Rajesh Kumar sir?
यस है माइक ऑन तो है हेलो
Sir, I can hear you.
अच्छा ओके वहां जा रहा है फिर
So as we move ahead with the last session for this entire GIAN course, I would request and wholeheartedly welcome and ask Professor HANNU LARJAVA to continue on the topic strategies for better wound healing and outcomes. And for this session, we have as a chairperson, Professor Rajesh Kumar Thakur, who is associated, and he'll be giving his concluding remarks post session completion. Over to you, Professor HANNU. Also, participants, please note that you are requested to fill the feedback form in the Zoom chat box. It is mandatory for you to fill the feedback form to get an e-certificate for the same. Thank you. Do we have Professor LARJAVA here? Professor LARJAVA, are you here?
I'm sorry, I lost you. My computer was shut down.
No issues, no issues.
welcome sir
Hello, can you hear me, Professor LARJAVA?
I can hear you now. I was lost for a while.
Yeah, no issues. So we move ahead with the final session for today on strategies for better wound healing and outcomes. For this, we have the chairperson as Professor Rajesh Kumar, and sir will be giving his concluding remarks post your session. And after that, we'll be having the valedictory ceremony post this session. So, and for participants, I would request you to please kindly fill up the feedback form. It is mandatory for the GIAN course to fill the feedback form for getting the e-certificates. Sir, could you please mute yourself?
So I can start now?
Yes, sir, you can start.
Yes, sir. Yes, sir. Yes, sir. Start.
Thank you very much. So this will be the last session for the course, and I was just putting few slides together, trying to think about how in the future maybe we can have some solution for better wound healing outcomes in oral cavity and maybe somewhere else as well. So I have a list in the end of the presentation, but I have a little bit of our own data that we have generated in our own lab, and that may also relate to some of the questions over the week regarding the patient-derived products such as leukocyte platelet-rich fibrin and so forth, so membranes. So I will talk about those first. And my first slide is showing my own leg that received a little couple screws when I broke my ankle with putting my motorcycle right on my ankle a couple years ago. So since then I have purchased a little lighter motorcycle so I can still ride, and my ankle still has those screws in place, and that they did heal okay, but you can see how they use staples and not like sutures that we do on skin wounds. But we will talk about the LPRF a little bit and some bone grafting materials that we have been thinking about, and some future materials that maybe can be used for improved healing in the mouth and other parts of the body. So I'm sure that some of you will be are familiar with the LPRF membranes and other platelet-rich products and nowadays there are so many that it's difficult to really know. The standardization is not always there, and there are different centrifuges and different angulations, and it's the feel is not very precise in terms of what the products actually are and what they do. So some of them I don't even call them LPRFs if they are produced in certain centrifuges like this Medifuge. They will ask them to call them some sort of growth factors, advanced growth factors and things like that. But nevertheless, this centrifugation of the patient's blood will produce in glass tubes these membranes that we can use. And then you can also create put your bone graft into these products and make a kind of like a sticky bone that you can put to augment the bone, like in this case from Dr. Paul Young. And then you can put those membranes on the top, and then the idea is that you will improve healing. And this has been in use for many, many years already, more frequently over the last, let's say, 10, 15 years than before. Maybe 20 years they have been in use, and everybody thought that they are the miracle things to use, but and sometimes they seem to give some advantage. This is from the Paul Young's case. Remember, areas where the extraction is required, and then implant placement will be very difficult. The base of the bone is not that wide, and there's no buccal bone, and then he did the LPRF and a sticky bone with outstanding results. So easy to place an implant in this kind of environment in the right position. So it seems to be successful, but is it only LPRF and the sticky bone in this case? But it has some advantages that cannot be ignored. So our group has also done few studies on LPRF, or whatever it's called, but it's the fibrin membrane that we produce, and we were looking at how it regulates gene expression in gingival fibroblast. So it was already well established that these membranes have growth factors in them, but we wanted to investigate what kind of a response the gingival fibroblasts will see when they face a number of different growth factors and cytokines coming from these membranes at the same time. So we wanted to see the response rather than what's in the membrane. We wanted to see what the fibroblasts will do with that response to these membranes. So this was published now a couple of years ago. So we isolated these membranes. So basically, you spin them down by the protocol. You use glass tubes because at least when you are using these for patients, you don't have any anticoagulants. You just put the blood in and you spin them down. There will be some clotting because the negative surface of the tube will induce clotting process, and then we get these membranes and then the blood clot, and we use the leukocyte platelet-rich fibrin. And now you can see how nice fibrin membranes we can get from one tube. So you can collect many of them, and we will discuss that in the end. So we were studying how these membranes, if they are put into the culture with fibroblasts, what do they do? How do fibroblasts see them? So we studied the gene expression levels, and many genes go up, some go down, like those fibronectin genes that are the cellular fibronectin forms found in the wounds, they go up. Collagen 1, surprisingly, it goes down, and some other matrix proteins go down. MMPs, many of them go up like 70-fold, and catepsins go up as actually they go down. So there will be changes in the many genes that we studied are changing by when the fibroblast cultures see these membranes in. So we put them in the environment where the membrane is on the like in the transwell, so not sitting right on the top of the fibroblast, but in the same culture. We also did wound healing studies where we make these standardized wounds and then see how the LPRF will promote wound healing in culture, in fibroblast cultures. And clearly you can see how much better they migrate when there's a presence of LPRF. So we looked the concentrations of the proteins in these what came out from those membranes, and we also looked how they regulate collagen, MMPs, VEGF, MMP3s, and so forth. So there's quite a large increase that we can see in these cultures when they are exposed to, in this case, what we call LPRF releasate, meaning that what came out from these membranes when they were incubated in the culture medium, and then we treated the cells with that. So there's also time response. So if you treat the cells with this release rate, then the collagen goes down and VEGF goes up, and MBs behave this way. So some go up and stay up, some go up and come down. So there's variation in the response. Some of the cytokines that these cells make, they don't make huge levels of interleukins, but in these conditions they go up quite a bit in these cultures. So and we find out that the main pathways that regulate many of these genes that we found that were upregulated in the cultures by LPRF were regulated by mitogen activated protein kinases, so ERK1 and 2 and P38, and sometimes JNK was also involved. So overall, what the studies were showing, and we did also some endothelial cell work looking at the potential blood vessel formation, like angiogenesis work. So LPRF by itself made these endothelial cells to form these structures that are typical for angiogenesis in culture. And then we also treated cells with the fibroblast condition medium that have previously seen this LPRF membrane. And they also, so the fibroblasts were producing factors like those VEGF and others, FGF, that were promoting blood vessel formation in culture. So it clearly shows that these membranes, how they are seen by fibroblasts, seem to stimulate their behavior that promotes wound healing associated gene expression. So, and also functionally, they seem to be healing the wounds better and inducing the blood vessel formations. So there seem to be some beneficial effects from these membranes, at least in vitro. Please mute yourself if you can. One of the questions that we were asking was that what happens if you have to wait until you put those tubes into the centrifuge. Many times clinician needs to collect if you are doing a larger surgery. So you have to collect many of these membranes. So you may have to have like 8 tubes or more. And then the question is that does that affect the quality of the membranes if some of the tubes are sitting on the bench because the blood collection takes time, so they may be sitting there for several minutes before they are centrifuged. So we will ask you what difference does it make if it sits on the bench before we put it. The recommendation is to put it in the centrifuge right away, and that's easy to do if you only have 1 or 2 tubes. But when you have 8 tubes or 10 tubes of blood, it takes time to collect them. So what happens if you keep them on the bench? So we had all these time points, like T0 is that when we put immediately after collection, it goes to a centrifuge, and then the T6 is 6 minutes later. So clearly, if you look at the mass of the membrane, so the membranes get gradually smaller if you keep them on the bench. But there's a lot of individual variation from patient to patient. And here you can also see that protein concentration of the membrane will correlate to the mass. So the what's in the membrane will also change in terms of proteins. And there are changes also how the membrane will regulate gene expression in fibroblasts. So if you look at a couple of these molecules, such as VEGF and FGF2, that, for example, regulate angiogenesis, blood vessel formation, there's clearly less regulation of gene expression if the tube sits on the bench 6 minutes before you centrifuge. Is again fairly large individual variation. And that's what we see throughout these studies, that, and we don't know why, one person's, and these were all healthy people and relatively young, why there's such a big variation in these membranes. And the variation probably comes from the fact that if the tube sits on the bench before or in the operatory, if you are in the clinic for longer time, like in this case 6 minutes, we will get much less leukocytes into the membrane. So this is the cell-rich area. So these membranes are not even. So where the red clot is, close to that area, there's a cell-rich area, and that is rich in leukocytes and platelets. So when we were looking at both of those, platelets are not really cells, but leukocytes significantly go down, and platelets even more so if you keep the membranes on the bench or in the operatory 6 minutes before you centrifuge them, because the cell numbers. So here you see the nice fibrin fibronectin fibrin stained by fibronectin staining. So this is how it looks like, those membranes. But the blue ones are the cells, and there are very few cells when you let the blood sit in the tube, because it starts coagulating before you centrifuge. So it doesn't happen in the centrifuge, it happens already before. So you lose many of the cells that are present in those tubes. So again, big individual variations, and variations if you delay. So you have to be aware that how you are handling these autologous products from the patient. So they may not be all the same if you are not careful what you're doing. So LPRF membranes have been used for all kinds of wound problems, and not only oral wounds, but also wounds in other parts. So there are lots of studies about using them for diabetic wounds and all kinds of chronic wounds. And the results seem to be fairly positive, like there's a wound that hasn't healed, and then you can see a number of different membranes have been placed, and probably a couple of times. And then based on this review, that the application seemed to be statistically superior to the control treatment that these patients have received. So it's pretty remarkable for patients having this kind of a healing result. So there is some evidence from extraoral that these membranes are promoting wound healing, and that's consistent what we also see in our cell culture experiments. The problem is that how everything is standardized and applied. So the question has been asked, this was in the Periodontology 2000, 2 years ago, actually, yeah, 2 years ago or less than 2 years ago. And the answer was, so they made a critical review of the clinical guidelines. So what they say that LPRF is easy to prepare, simple to manipulate, and not expensive, and it's a patient's own product. So many people are using these GPs and specialists in oral surgeons and periodontists in Canada. So it says that it offers a number of benefits: sinus floor elevations, you can protect the membranes and regeneration, although there's not that much evidence that it's by itself will help. Then there are, you know, donor sites for the grafting, there are extraction sockets, and people are using them pretty much everywhere, but not everything is scientifically proven that it will have a positive effect. But it say that it's promising, but I think then the important question that they asked that what kind of benefits we will get in more demanding conditions that we still don't know, like elderly people, smokers, compromised, diabetic, and so forth. So most of the studies have been done with healthy adults, so we don't know how compromised patients will benefit from their own products. So using them in some conditions doesn't seem to give a lot of benefit. So thus filling the extraction socket may prevent or help with dry socket formation, but it doesn't really offer much ridge preservation. Like in this study, they say that it did not diminish the need of the further bone augmentation for implants. So it was comparable to unassisted healing. So blocking every socket with, excuse me, with LPRF doesn't necessarily lead to better healing outcomes always. Soft tissue may heal a little better, but in terms of the bone recovery, you may still need your bone graft. I mean, if you do a bone graft and put the LPRF membrane on the top, I think that would be fine. So if people want to look at the various instructions for LPRF treatments for clinicians, Kurinen and others have published this paper, Periodontology 2000, and they have nice videos showing how to do various procedures and how to use LPRF in these procedures. So if somebody is interested in looking those, you can get there in using that link. We also use LPRF because we were thinking that it may have some antimicrobial properties based on the content of those cells. So we did a study published a couple of years ago when we were trying to decontaminate implant surfaces by using LPRF. As I explained to you yesterday, the decontamination of rough implant surfaces is a major clinical problem, and we don't have a very good solution. So we were doing a in vitro experiment where we cultivated those multi-species biofilms on implant discs, and then we placed the LPRF membranes on the top of the disc that had the bacteria present, and then we were looking what is the effect. Does that improve the decontamination by not doing it mechanically and not doing it with chemicals, but doing it with the patient's own blood products? So this is the our 3-week-old multi-species biofilm on the rough implant surface. these are the SLA surfaces that Stroman is using. So these are the, after rinsing this, most of this biofilm gets off, but many of the bacteria, mainly some filaments and coccoid bacteria, probably are the first colonizers. They they stay in these rough pits and lagoons. And after LPRF treatment, surprisingly, the rough surface looks relatively clean, like somebody has cleaned these bacteria away. And we were interested in knowing what that could be. So first of all, we were calculating the number of bacteria that are present if we treat the rough implant surfaces with LPRF. And we had 12 different donors. And in all cases, they were not sterile, but the bacterial numbers to the control dramatically dropped. And in some cases, there was very difficult to find any bacteria on those discs. So clearly there was improvement in the decontamination of the discs. So then we did one disc where we did, because how we do the experiments, that we will put the biofilm on the top, then we rinse, and then we put the materials on the top, and then we remove them, and then we rinse again. So we, in the previous slide, like I was showing you, the membrane has been removed and the disc has been rinsed once before in both cases. So we did an experiment where we decided not to rinse it, so see that what's going on the rough surface, and this is what we see. So you can see all those little blobs, little round things that have a lot of philopodias, and we believe these are the platelets rather than leukocytes based on the size and morphology. And the little round things are the coccoid bacteria. And if you looked very carefully, there are two of these little platelets that are kissing one bacteria, and it's full of holes. So what happens here is that these have a death kiss to those bacteria, so they basically are touching them and creating holes into the membranes, and then the bacteria cells get the liquid going inside, and it will just burst and die. So that's how we think that they are not phagocytizing them, they are killing them. And then we were looking at the bacterial amounts, that are numbers that have perforation in them. Like you can clearly see that this round ball is full of holes. Some of them are not full of holes yet, but many of them are, especially those that are close to the platelets that are acting up. So it's not surprising that to see platelets being also antimicrobial. They can be, and it has published before. So many of these, so about half of those cells that we were able to see had holes in them, and half didn't. So it depends how close you are into the platelets. But you can see that they all went to the almost fit perfectly into the pits and lacunes of the rough implant surface. And if you rinse this off, then the bacteria and everything looks clean. So so we haven't done an experiment putting this in a more clinical environment, because those are a little more complicated. The idea was that because we always do conservative treatment with peri-implantitis first, that we could do experiments where we have patients who have implants that need to be removed, and we could actually try to do treatments on them by putting this into the pockets, deep pockets, and trying to treat the conditions before removing the implants and doing examinations, or just do a clinical study with the moderate periodontitis and back them with the LPRF membranes, and then, I mean, maybe that's something that we could do collaboration with your universities in India, where we could put these membranes into the patient's peri-implantitis lesions, and then, you know, have a protocol, and maybe a couple colleges could do a few patients each. I mean, that might be a good research project that we could do together, and then look at the clinical parameters after, whether this will actually be clinically feasible. We haven't moved to the clinical part, and that will be something that maybe we can do together. So the last couple of slides, I'm going to talk about our review paper on the bone, synthetic bone ceramics that we have been thinking about in the past. So we published this a couple of years ago. Instead of using the xenografts and allografts, we could use synthetic bone that some patients will probably like more than having animal or human derived bone particles. So we were thinking about how, because we know that hydroxyapatite is not ideal because it doesn't really resorb. That could be have a combination of hydroxyapatite and calcium phosphate, such as beta-3 calcium phosphate, together. That will have a combination of good size of pores, and also the cells will be more able to resorb it. So that's what we were kind of speculating, how these ceramics will work. So we will have this biphasic calcium phosphate product that has hydroxyapatite and beta-3 calcium phosphate minerals that then will be eaten by osteoclasts, because they can't really do much with the hydroxyapatite by itself, but when it's a biphasic product, they can resorb it, and then the osteoblast can come and replace it by regular bone. So there could be some bioengineering advantages on working on synthetic bone grafts. They can be probably made more osteoinductive, because currently they are just osteoconductive at the best. So I think the field is moving, trying to manufacture bone ceramics that will be better than the products that we get in allografts and xenografts. So that probably would be something that happens in the future. So here is an example. For example, if you have a ratio of 60% hydroxyapatite and then 40% beta-3 calcium phosphate granules, that then the bone will just keep forming around it, and osteoclast can dissolve this ceramic, while they can't do anything much with the hydroxyapatite. So one important aspect in these bone minerals is it's the micro or nano and macro structure. So ideally, they will have two kinds of holes. They will have bigger holes and smaller holes, and people have tried to figure out what kind of a hole size or the pore diameter they should have. So there are several publications in vitro looking at different diameters of the particles in general, and also the pore size in the macro and micro pore size in these particles that may play a role. I don't want to go to details of these products, but this is something that is probably evolving, and people have been quite interested in this review, trying to look into the future of bone ceramics that will be better and more osteoinductive than they currently are, because that will be a big change without necessarily incorporating a lot of growth factors and things like that. But that could be also part of this bone ceramic. So you will have an ideal bone ceramic with some bone growth factors like PMPs. And my final slide, I was trying to put things together. What could be the better strategies? Will be the formulation of controlled release films that are muco-adhesive, so they stick into the mucosa or gingiva that can contain microparticles, nanoparticles that can be antimicrobial agents, growth factors, all kinds of things that you could incorporate that may change the wound healing outcomes for soft tissues. You could have stem cells. We haven't really discussed stem cells much because they are not really in routine use yet, and they are a little bit more cumbersome to use, and you really have to think about when those will be used. But they could be used they can be primed, and they can be printed in 3D scaffolds, such as those bone ceramics, for example. It could be a combination of cells and matrix and osteoinductive properties of the bone scaffold. Another option would be to apply external electric fields or electromagnetic, or for doing photobiomodulations or ultrasound. So those kind of things have already been experimented to some degree, but they are not there yet. But they all could be potentially used for advancing wound healing in the bone and potentially also in the soft tissue. And the grafting materials for osteoinduction I already discussed. I think the next easier thing to get will be those 3D bone grafting devices. Like, I think we already have almost a technology where you can take your CT scan and you could just print the bone graft, and you could have the pore size that you want and the material you want, and then your bone graft will be ready to go. It will be like a block graft instead of having these particles that float around and are sometimes difficult to handle. So you will just open the flap, you put this previously printed bone graft that is in one piece into the place, and you close the flap. So, I mean, that is probably a few years away, but I think that would be relatively easy to, even if you don't have osteoinductive, but osteoconductive devices would be the easiest to start. And for periodontal regeneration, we might need additional and combination products, such as not only the factors that can regenerate, but also combinations of antimicrobial agents and those factors in the same device. And there are probably many, many more things that will come along when the research will advance. So that is gonna be my last words. I will thank the organizing committee and the whole group who has been part of this course. Also, of course, the participants of the course and the organizers, and especially SAIF, who has done a lot of work getting this thing together, and hopefully it was a successful and interesting week for everybody, and I thank you so much.
Thank you so much, Professor LARJAVA. Am I audible?
Yes, you are.
Dr. Rajesh Kumar Thakur, please summarize
Yes,
the.
sir. Thank you so much, Dr. SHOEB and the team of the AMU for arranging such a wonderful program. And I am privileged to be a part of this. And thank you so much, Professor HANNU Larwaj, for delivering a wonderful, so exhaustive in each and every aspect of the wound healing. And I am sure that all the participants will be benefited of this. And this growth factor approach of this PRF, which is commonly used nowadays by the patient, will surely help in improving the wound healing as well as the periodontal degeneration. We can improve this periodontal degeneration by changing the either three factor cells or scaffold or the signaling molecule, and keeping the site favorable for the cells away from the microbes irritating factors as well as the risk factors. By this, we can improve the healing. Thank you so much, Professor HANNU Larwaj and the SAIF and the team AMU for organizing this program, wonderful program. Thank you so much.
Thank you, sir.
Thank you.
Now we may move to another ceremony, valedictory ceremony. May I now invite Dr. Aman Ali to conduct the ceremony. Over to Dr. Aman.
I hope I'm audible to the audience.
Yes.
Good morning, as well as good evening, Professor LARJAVA. As we reach to the conclusion of this remarkable GIAN course on oral wound healing, I extend my heartfelt gratitude to all the distinguished speakers, participants, and organizers who have contributed for making this event a resounding success. Over the past few days, we have explored the details of oral wound healing guided by some of the most esteemed experts in the field. Each session has been an enlightening experience, providing invaluable insights that will undoubtedly enhance our clinical and academic pursuits. A special acknowledgement is due to Professor LARJAVA, whose expertise, dedication, and engaging sessions has left an indelible mark on this course. As a token of appreciation, I may now request our esteemed Dean Faculty of Medicine, Professor Muhammad Habib Raza sir, to address the gathering and kindly release the appreciation certificate for Professor LARJAVA.
Thank you very much. It's a pleasure, and this is the valedictory ceremony for this course. And for the last 5 days, we have been seeing that a lot of scientific activity was going on, and Professor LARJAVA, he has done a commendable job. And I came to know from some participants that there was multiple universities were involved, and there was an interactive session from 10 colleges, and there were a lot of participants in that. And now I think that it is high time that we appreciate the hard work, and I also thank the participants and the organizers and the GIAN team for having this excellent workshop. And since he's so far away from us, he's in Canada and we are sitting in India and getting benefits from his golden words. So this is the right time to appreciate and to say thank you to him. And also thank you to the whole team of the dental college, the principal, N.D. Gupta Saab, Dr. Saif Khan Saab, and coordinator, Professor Vibha Sharma, all those who have worked day and night to make this workshop a good success. And I think this is high time that we once again thank Professor LARJAVA for sparing his valuable time and interacting with the people of this country, and for the whole whole sessions which he devoted so much time. And I look forward that in future also, whenever we need his services, we'll request him and he will be participating in that. With these few words, I want that the ceremony is going to come to an end, and we allow that certificate to Professor HANNU S. LARJAVA to be delivered to him right now. This is the certificate of Professor HANNU S. LARJAVA, and the topic for this was oral wound healing and management of oral wounds, and it was organized by the GIAN team. So best of luck and thank you very much. The second certificate to be issued to Professor N.D. Gupta, Course Coordinator. This certificate is being given to Professor N.D. Gupta for his hard work and for being such a good organizer of this workshop. And I congratulate him for getting this certificate, and he deserves it.
Thank you, sir.
Now I call upon the main person who initiated this program and who is also in close relation with Professor HANNU LARJAVA, Dr. SAIF Ali Khan. I think he requires a big hand. Give him a big applause for his hard work.
Thank you, sir.
So I think the dental college has set an example for the whole faculty of medicine and the university that such courses can be organized in this manner also. Previously, physical presence was needed, but now this option is with us. And I think this will go a long way in helping other faculty members, other departments to organize this type of conference. So again, I congratulate Dr. SAIF Ali Khan, SAIF Khan, and the course coordinator, and give him this certificate on my behalf.
Thank you, sir.
Now, the last person, but not the least, is Professor Vibha Sharma, the local GIAN coordinator, who has helped us in organizing this workshop, and it has been a grand success. I congratulate her and look forward for a cooperation in other endeavors also in the near future. This certificate is for Professor Vibha Sharma. Thank you. With these few words, I think we close this session, and I think whatever is left, Dr. SAIF Ali to continue. Thank you.
Thank you so much.
Thank you, sir. Moving forward, I sincerely appreciate the contributions of Dr. SAIF Khan, the course coordinator, Professor N.D. Gupta, sir, the co-coordinator, for their support and guidance in organizing this program. I would also like to express my gratitude to Professor Vibha Sharma, the local GIAN coordinator, Aligarh Muslim University. I now request Professor R.K. Tiwari, sir, Principal Dr. Ziauddin Ahmed Dental College, to kindly address the gathering. Sir, kindly unmute yourself. Okay. Sir, you're not audible.
I'm audible?
Yeah, now, yes, sir.
So, Dean sir has already appreciated the things, but as the principal of Dr. Ziauddin Ahmed Dental College, it is my honor to recognize the outstanding contributions of our esteemed speakers, coordinators, and participants. Their dedication has made this GIAN course on oral wound healing a great success. With gratitude, I now proceed to release the appreciation certificate, which is, I think, has already been released. Thank you very much.
Thank you.
Thank you, sir. And finally, I am pleased to announce that the certificates for all the participants, as well as appreciation certificates for our respected speakers, moderators, and session chairs, will be released soon after receiving your feedbacks. Finally, as we close this chapter, I would now again like to invite Professor LARJAVA to deliver the closing remark.
So I would like to thank again the university administration and the GIAN coordinators and everybody else who was involved organizing this course. And my special thanks goes, of course, to my friend SAIF Khan, who was instrumental putting this together and inviting me over. So thank you for that. So I was a little hesitant when I realized that my travel plans will not be successful for this course, and I have to do this online, and all the time, time this. Please mute. Please mute your microphones.
टाइम तो उसी डेट में करेंगे ना, कोई महीने भर की छुट्टी कर नहीं, म्यूट कर दी.
So I was planning to say that I was a little hesitant. Can I continue?
Yes, yes.
So I was a little hesitant when this became an online course instead of in person, because for a couple of reasons. I really wanted to visit India because I have never been in the country, but unfortunately that didn't work out this time. The second, I was a little reluctant how this will work online because of the time difference and sometimes glitches in Zoom and the PowerPoints and all the rest of it, and then especially how the case-based learning might work when we do it online with such a large group. But overall, I think the things went pretty smoothly, except my computer shutting down a couple of times, but it wasn't really a major hindrance for the course. So it was very nice to be a member of this participant in this course and giving some of the talks that and presenting some of the data that we have produced in our own research and trying to promote periodontics in all aspects of the field. So I'm very honored to be a speaker for this course, and I thank everybody for inviting me over and giving me this chance. So thank you very much.
Thank you so much, sir. And for your plans about visiting India, I hope that you visit India soon, and we will be pleased to host you anytime.
Thank you.
With this closing ceremony, I would further like to invite the local GIAN coordinator, Aligarh Muslim University, Professor Vibha Sharma, ma'am, to address the gathering.
Good morning. A very good morning to all of you. I hope I am audible. That is the first question that we are supposed to ask in online mode. So I'm very happy. It is indeed a very, very gratifying experience for the local coordinator, because my role is to negotiate between the central agency and the university. And I can see that with the efforts of very, very distinguished foreign faculty, Professor HANNU S. LARJAVA, and the Dean, Faculty of Medicine, Professor Muhammad Habib Raza Sahab, Principal Dental College, Professor R.K. Tiwari ji, Chairperson, Professor Neha Agrawal, and the coordinator, Dr. Saif Khan, along with co-coordinator, Professor N.D. Gupta. This course is a grand success on a topic which is so important, especially in India, which is a country where oral health care is a big concern, from metropolitan cities to small towns to villages. And to have discussed oral wound healing and management of oral wounds in such a detailed manner, in such a sophisticated manner, with the help of animation-based PowerPoint presentations and in-depth lectures, interactions, tutorials. This course has definitely proven that if we decide, we can also create a very, very pragmatic world in the virtual space as well. Clinical sciences are difficult ways to take care in virtual space, but I must congratulate Dr. SAIF for having wonderfully performed this duty of sending out wonderful lectures, arranging such good speakers. And I truly appreciate the great hard work and meticulous disposition that Professor HANNU S. LARJAVA has displayed. It is really very inspiring, that according to Indian time, it is 8:15 a.m. here, whereas you have a little early in your country. So, managing time differences, and I can see it is such a well-attended course. Always some, people are there, 80 to 100 and more than that. So this is a very interesting development. I think the dental college, Ziauddin Ahmed Dental College of our university will make the best of it. For me as the local coordinator, all the boxes are checked. Everything is in right place. So I am very happy. I congratulate all the students, all the participants, and I also wish that someday we will be able to host Professor HANNU S. LARJAVA in our university in person mode. So we will look forward to having those opportunities in future as well. Thank you very much.
Thank you so much, ma'am, for your support and guidance throughout this course. So, last but not the least, I would like to invite Professor Dr. SAIF Khan sir to give us the closing remark of the course.
Thank you, Dr. Aman. Respected Dean sir, Professor HANNU LARJAVA, Principal Professor R.K. Tiwari, Chairperson Dr. Neha, and all the faculties and students joining all line from across India. It was a very well organized and show. It was because of the meticulous planning which my students were at the backdrop. They were managing and micromanaging everything. A special mention to all my postgraduate students who were there and my technical team who was always on my call, and they made it sure that everything is smooth, everything is seamless, and it has been a great learning for 5 days. There were mind-opening evidences which Professor HANNU brought, and definitely it is going to help us in our clinical practice for better patient outcomes. I think Professor HANNU should be commended for sitting for 4 hours. It is evening in Vancouver. I think it's night right now. He has to go to bed, but he's sitting straight and giving lectures. So this is the commitment, and what I can say about you and your patients. You had very suffer much for this course. You had to go to embassies and everywhere, and but you persisted and you agreed, and you are here, and you have justified your academic leadership. Your commitment is commendable, sir. And I would love to have you here in Aligarh for a or bigger and broader thing to, and a better collaboration with AMU. The collaboration of UBC with AMU, because both universities are 100 years old, and we can have a very wonderful collaborations. Your researches and our clinical material can be a good conglomeration of new vistas to open for our university also, as well as your university also. I think the university administration will also take heed of it, and will have a more good sessions on that also. With these remarks, I thank everybody who was there, however, I could not name them, but I thank my participants, the faculties, the chairperson from various colleges. This program witnessed from across all part of, from South India, from North India. It was a pan-India program, I could say, an pan-India international program. And your scintillating lectures, Hanu. So,
thank you so much for your kind words.
So we can leave right now. And Doctor, good night and good day.
Have a good day, everybody. Enjoy the rest of the, I suppose, weekend.
Yes.
So
Yes.
have a lovely day. We will see you again.
Yes.
Bye-bye.
Bye-bye. Thank you.
Thank you, sir.
एक मिनट ये कह दो कि लोग आज से क्लास डाल देना ठीक है Let's put it in there.